Okay, good morning, everybody. We now have another session on vertebral body tethering, which, as we heard earlier on today, is something we're increasingly talking about with our patients and with each other, but something most of us don't currently offer as a treatment option. It's a great pleasure to introduce Mr. Jason Bernard, who works at St George's Hospital in London. He almost certainly has the biggest active practice of vertebral body tethering in the UK. He's going to share with us his experiences of using the technique over the last 5 years.
Well, it's been 5 years of nervousness and anxiety, but I'm hopeful that we're going to have something worthwhile to tell you. But let's keep in mind, how much does it matter? Are we going to be giving up our fusion surgery? Are we able to produce correction without doing a fusion? And if we can, is it a predictable process? And if it is, should we do it? And is it better than what we already had? Well, I would ask you to examine fusion with fresh eyes. Imagine that it was a novel procedure, not previously used. Imagine you saw this kind of dissection and looked at the terrible soft tissue damage you were doing, the stiffness you were going to create, the abnormal muscle that you would find before and after surgery. Imagine all that and think how stiff the poor victim would be, how much implant there is. Well, you might find it difficult to get people to start doing that operation. Now, by no means are all fusions as badly afflicted and stiff as this youngster seems to be. However, the more that we include the thoracolumbar spine and go into the lumbar spine, the more that this kind of unnaturally stiffness with not a jot of movement in it becomes its own movement disorder and its own disability. And just remember that the 2 or 3 caudal discs will degenerate in midlife in any case, how much more so with this kind of load above them. And just to prove that there is nothing new under the sun, this was first thought of, as far as I know, back in 1969 by Dwyer, who described actually an anterior compressive growth modulating system, and that's how he wrote it up and thought of it. The results were not good enough either because of the system, the patients, or the technique, but the principle was considered, as indeed was the distraction principle for correction. So we'll leave the year that Neil Armstrong first walked on the moon and I was going into nappies, and we'll move towards the present day. Research is continued, however, and stapling of the vertebral bodies was tried in an attempt to find an animal model for scoliosis. In order to test vertebral stapling, the tethering systems were developed in goat and pig models. A happy consequence of experimentation on animals. Over the millennium, or what we might call the turn of the century, Dr. Betts and John Lubicki did some studies with staples. The results were of interest, but mainly because they showed that staples were not capable of controlling any clinical size of curve. There was some modest success in smaller curves under 40 degrees, which could be persuaded not to progress. However, that was not sufficient for clinical needs. In 2010, Lenke and Crawford published a case of a male early onset scoliosis patient who had an anterior tether to correct his scoliosis during growth. And it worked beautifully, and rightly they will be remembered for that. This work probably did more than any other single act. Despite this, Professor Lenke is very, very happy to continue doing posterior fusions, and perhaps he knows something that we don't. The physical mechanism of a tether system is fairly straightforward. Screws are placed anterolaterally into the vertebral bodies. They have an open tulip head, and a plastic polyethylene cable is tensioned between them to compress the growth plates. This can be done through open or endoscopic procedures, and on the right you see the parietal fluid over the ribs, the deflated lung, and the row of screw heads in the vertebral bodies. Stefan Parent has looked at the bone changes which occur, looking at serial EOS images, and in those patients of his who had growth modulation, he found that the convex side effectively did have growth arrest, and the concave side grew at an effectively normal rate of nearly 1 millimeter per year per level. I think this is important. It demonstrates that the Buter-Volkmann principle can be reversed and used to correct the curve, but it also shows the importance of offloading the concavity of the curve. Therefore, it is not enough simply to place a restricted tether on the convex side, but you must also produce enough correction to normalize the load across the disc and growing end plates. In 2014, Amirsamdani published, along with Betts, a small series of thoracic vertebral body tethers with good early results, and since then there has been a great deal of interest. The results were used for a Zimmer submission to the FDA, which was approved last year. You can see in the FDA results that modest curves of around 40 degrees were corrected to 20 degrees without interfering with thoracic kyphosis or total thoracic growth. This is, of course, an excellent aim, and if it's reproducible, would be worth more widespread use. Since then, a slew of other publications have followed with similarly encouraging results. We have recently had the opportunity to review 20 of our patients with a follow-up of 4 or 5 years. This is very timely, and it is a great opportunity to share what we have learned. We've treated the group of children as 2 separate groups, one skeletally maturer than the other. So we have split into RISA 0 to 2 and RISA 3+ for general purposes of analysis. Rather conveniently, although entirely by accident, there happened to be 10 in each group. 11 curves were instrumented in the younger group and 12 in the older group, due to the presence of double structural curves in some patients. All of the youngers were female, one of the elder group was male. Ages are as shown. 4 out of 10 had open triradiate cartilages. The majority of the curves were single right thoracic curves. There were a number of lumbar curves, and some of the double curves were treated as lumbar. Some of the curves were double thoracic curves. The number of levels operated varied between 5.5 and 10, depending on the location and length of the curve. But the general principle was to instrument from cob to cob anteriorly. Curve selection was between 40 and 60 degrees in these patients, and therefore it's not surprising that the mean cob is 47 degrees in the younger group, and perhaps a little more advanced, 56 degrees in the more mature group. The bending COB film showed that the older group was stiffer with only 44% correction. Despite this, they had much better correction, 80% of the initial curve corrected. In many ways, this is because the skeletally immature group had deliberate undercorrections to take into account ongoing growth and to try and avoid overcorrection as a problem. Follow-up is 5 years on the younger group and 4 years on the slightly older group. There were no intraoperative complications, and blood loss averaged around 150 mils. There has been one revision to loosen a tether, and the same individual has now had a posterior thoracic fusion, and we will look at that case later. There have been a number of tether breakages. Disappointingly, the final COB angle is more than 35 degrees in 2 from each group. However, none of those have sought for the surgery. Displayed in a graph, the skeletally immature group have initial correction to, roughly speaking, the bending film, and then spend the next 2 to 3 years undergoing spontaneous correction with further growth. At 3 years, one had the tether loosened, and that brought the average back up. The more skeletally mature group did not have the same correction with growth, but has stayed well corrected, allowing for a little loosening of some of the tethers. SRS scores showed a satisfactory improvement post-operatively at 2 years, and that remains at the current time points of 4 and 5 years. The scar tends to be an 8 centimetre scar that sits under the bra strap line on the right or left side. If the procedure is done in an open manner, this is well hidden by ordinary undergarments, and flexion, as you can see, is good with a natural thoracic kyphosis. In younger patients, endoscopic techniques can be used, and 3 centimetre incisions is appropriate for this and heals well. Now, this is not going to immediately change all treatment. Apart from the potential for revision, it's important to understand that small and flexible curves are not the commonest type. We've looked at our presenting population and found that perhaps less than 10% would be suitable for bracing, and 20 to 25% would be suitable based on COB and maturity for a VBT treatment. Therefore, we have to decide whether we should push for earlier detection of smaller curves with more intervention but perhaps less fusion. Those fusions that are done could make use of more anterior short segment fusions, and perhaps leaving long posterior fusions as a salvage procedure for those who present late or whose earlier treatment does not work. I would say that early definitive fusion also has a high revision rate, around 30%, and it may just be that the nature of these early scoliosis presentations means that they're difficult to predict, and the treatment will always be fraught with some degree of error and revision. If we are to move along a path of seeking smaller, more flexible curves, then we will inevitably have to treat many more patients, and this may present its own problems, both the risks of overtreatment, the risks of surgery, and perhaps the costs overall. But if it allows us to produce a more normal outcome without fusion and with fewer fused segments, then this may be something that's worth considering over the next 2 decades. However, life does not always run smoothly, and there are potential operative dangers lurking. Particularly in the thoracic spine, screw placement is a real issue. My preferred position is somewhat like this, entering mid-body in the convex side and exiting near the rib head on the far side. This keeps it out of the way of the aorta and out of the way of the spinal cord, which is ideal. However, I have seen eminent surgeons from other places place screws in these positions, and I know this because I have removed them, and I'm not possibly the only one in the audience who has had to do so. Therefore, we must be very careful about screw placement. We must certainly not be complacent about the ease of this kind of surgery just because it uses words like percutaneous, endoscopic, or minimally invasive. Where discs are wedged, it has been my preference to excise them and to fuse those discs at the same time with proper disc preparation. In a moving person, any implant is subject to wear and tear and has a fatigue life and will experience breakage or loosening over time. This is no exception. That is why it's essential that something will make a permanent difference to the shape of the spine before the fatigue life of the implant has been reached. In the younger patient, it is certainly possible to produce growth modulation. In the skeletally mature, either disc fusion at the apex or some other variety of disc surgery would be required. Dr. Betts presented a series of lumbar osteotomies to correct scoliosis without fusion around 2 decades ago, and it may be that that could be an alternative in some cases, although I should emphasize that is not something that anyone is currently doing or recommending to my knowledge. I would conclude that we've shown a high success rate in helping children avoid fusion. In my hands, this has been a safe technique, although we must not at any point become complacent because the dangers are clear and very present. This report shows that VBT can correct the spine and create growth modulation. However, I think lifetime follow-up is going to be necessary before we can say that it truly is a lasting cure. I'll present some cases, and you will note that they are by and large small and flexible curves, because that is the kind that has a chance of responding. Large and inflexible curves, where you feel you have a lot of correction to do, are really not appropriate for this technique and should not even be considered. This is a double structural curve, which was very well treated by approaching only the lumbar curve, and in fact some correction of the thoracic curve has occurred over time. Balance remains good, as does flexibility. This case shows moderate flexibility of a moderate sized curve in triradiate open. The implant was placed endoscopically, and 3 bunches of screws can be seen relating to the portals. The growth modulation occurred in a very pleasing way. This is a similar case with open triradiate and a lot of trunk shift in the curve, and although this is not the final X-ray, you can see good correction of growth and correction of trunk shift has occurred. And again, this is a similar case showing that the triradiate cartilage being open certainly provides enough growth to drive correction over time. This is another double structural curve, lumbar dominant. The treatment of the lumbar curve is all that was needed, and the thoracic curve has actually corrected itself with growth as well. The case which required revision started as an early presentation at the age of 9. After brace treatment, she escaped treatment and had a 60-degree progressive curve with triradiate cartilages open. The mother did not want growth rods, as she had a friend who'd had a bad experience with them. The spinal cord was normal, and there was moderate flexibility on the supine image. At surgery, the screws were placed, and all had a good purchase on the bone. Correction was to make the end plates nearly parallel, and that was maintained in the early supine images. Interestingly, the thoracic spine remained quite straight throughout. The main curve came in first standing X-ray at 14 degrees, but what you can see now is that there is a proximal thoracic curve, and that's something to watch out for because it becomes important later. She growth modulated, and her correction of the main thoracic curve was very pleasing. However, you can see that the proximal thoracic curve did not correct with it, and in fact, if anything, became worse, causing some imbalance. She remained very straight in the thoracic spine. As you can see from the left-hand image, she developed some overcorrection at the thoracolumbar junction. The revision surgery was not difficult and blood loss was minimal. I simply loosened the tether and gave her 2 millimeters of additional length between each pair of screw heads to accommodate further growth. This worked well, and she had 0 degrees of thoracic curve as she grew older, but the proximal thoracic curve continued to slowly progress. As it did so, it started to cause some imbalance, and the thoracolumbar angulation developed to compensate for it. As she approached skeletal maturity, this overbalanced her somewhat and left her with trunk shift again. What's interesting is that on her supine pre-op CT scan, the spine actually comes pretty much completely straight, and the thoracic part of it is at 0 degrees, which would have been ideal but for the proximal thoracic curve. And this is a case that perhaps we would not have treated with a thoracic growth modulation technique in retrospect. She had a very straightforward fusion, as the spine was pretty much straight to start with, and it corrected the shoulders and proximal thoracic curve well. She's now doing well. Thank you very much for your attention. I think we're open to questions now.
Thank you very much, Jason. That's an excellent talk. It's really interesting to hear your thoughts and see some of the cases that you've been dealing with. And as we expected, we've got lots of different questions, so I'll try and get through as many of those as possible. The first one's from Neil Davidson asking, how do you estimate the amount of undercorrection to try and aim for in the kind of the RISA 0 to 2 group? And moving on from that, Adrian Gardner has said, if you're trying to estimate, is it possible to build a predictive model to help you do that? I think you're still muted, Jason.
Do I need to? There we go. Am I on now?
Sorted it. Yeah, you're on.
We have sound. Perfect. So I think there's a minimum that you have to do to offload the concave side, and that seems to be around 30 degrees. So if you leave more than 30 degrees, you don't get growth modulation, which is very disappointing. The amount you should leave, really, I think it's per year of growth is how it's going to work out. And so if you have a Sanders 3 and you've got 3 years of growth expected, you can kind of guesstimate you're going to need to leave all of that 30 degrees. If your tri-radiate's closed, and especially if you've got any RISA visible, then you probably want to get under 20 degrees so that it's a final satisfactory result, even if there's minimal growth modulation. So, I mean, my experience was that if you have a RISA visible, you get very little growth modulation change. And so I think it's that grip between tri-radiate cartilage closing, Sanders 3, and RISA appearing I think that's a very difficult ask, but under 30 degrees for sure, and as close to corrected as possible if they've got a RISA, if that helps. there is some predictive stuff being done. Stefan Parent's probably the furthest along of anyone with this, because he's been doing EOS, and his engineer, Eric Aubin, has been putting this into a predictive model for growth. And he showed even 4 years ago at the SRS that he could pretty much predict whether you'd get lumbar decompensation after a selective thoracic curve. And he was able to predict to some extent what the progression risk of a curve was. But more recently, he used it on his tethers, but after he had operated on them. And he was able to predict within 5 degrees what the outcome would be 2 years later. And so, whilst that's not pre-operative prediction, it's the kind of work that's going to lead to it. And I think so. Stefan Parent's going to provide the best answers to that.
Ashley Coles made a comment about a paper predicting height, eventual height as an adult in children. And Darren Lewis mentioned that the fulcrum bend view was something that you looked at in your series to help with prediction. Do you think those things are going to help with prediction of undercorrection or prediction of whether or not the treatment's going to be successful, or a bit of both?
Yeah, so it's all going to end up being part of the mix, but it works out as being end plate potential for growth is just about 1 millimeter per year during the rapid growth phase. And so it's about being able to predict how many years of that there's going to be between you doing something and the end of growth, and whether those millimeters per year over, say, 5 apical vertebrae is going to be enough to solve the problem. Final height is a bit tricky because there's a lot of leg involved in final height. And if you're talking about 6 to 8 segments of the thoracic spine or the lumbar spine, that doesn't contribute so much to your final height as an adult. There's maybe 2 centimeters in it. So that is more difficult to see how that works into it. But yeah, the finite element models that Stefan Parent's been doing, because he takes an EOS sanding and then loads the child. And so he can produce a finite element model with some actual real numbers in the stress strain curve for the moving parts. And I think if you can do that and you've got actual vertebral body heights for concave and convex, then you're starting to look at a predictive model that you can really start to say where it'll be in a few years. But that's, as I say, what he's done so far is based on post-op. And I think what we've got is, if the tri-radius is open, it's a bit of a random outcome how much growth they're going to have. That's really been unpredictable. And Peter Newton would say that, and anyone who's done a definitive early fusion would agree. If the tri-radius is open, anything can happen anywhere else in the spine.
Yeah. No, understood. Chris Adams raised an interesting point. You talked about doing apical fusions or disc removals, disc releases in some patients. How do you decide which ones you choose to use that for? How does that affect their movement, and what do the patients think post-operatively when you've done that?
Yeah, so it's fairly simple. If a disc is already wedged, it's definitely not going to turn into a normal disc later. Yeah, so if it's not a nice quadrilateral disc, then it's not suitable to do any kind of tethering operation on, because it's not going to growth modulate. And so if a patient is insistent that that's what they want to do, and they understand that the only way to do it will be to fuse that disc, then I'm prepared to go ahead on that basis. But yeah, they lose the movement in 2 or maybe 3 discs. But as you would say, less fusion is still part of the goal. And if 2 or 3 discs are sacrificed, that's better than 8 discs being sacrificed, or a fusion of 12 or 14 levels. So I think it's all a question of scale. And Peter Newton described it almost a dose response curve. The further you go beyond T12 into the lumbar spine, the worse the functional outcome is. So it's all about avoiding a maximum amount of fusion and keeping it to a minimum.
Okay. There's a nice controversial question from Mr. Davidson saying, if this is a treatment which is particularly good for smaller curves, is it time to start thinking about revisiting school screening? What are your thoughts on that?
Well, it ties in. You've got low dose X-rays like EOS now, so it's not as risky. I think school may be the wrong place for it. I think it may just be a public awareness campaign. After all, if you can teach the general public to recognise a stroke, with a simple set of adverts, you can certainly say, what do you get your child for the 10th birthday? You get them to bend over and look at their back. And if you just, you could easily just raise public awareness, and the mums nets of the world would quickly disseminate that information. So you could certainly do that. As I said, there's a floodgates effect. Weinstein's distribution curve, of curve size would suggest that you go from 0.1% of the population at 40 degrees to 0.3%. And so you're talking about treating 3 times, or at least screening 3 times as many people. You maybe brace a lot more of them. But, I'm not against it. I mean, my goodness, look at things like breast cancer and other cancer screening programs that have had enormous popularity, are all based on the idea of pushing the curve. So as you're treating less severe disease and allowing people to get better outcomes. So I think it's not a bad idea. We just have to have our eyes open about what the consequences would be. And the surgery has to be done absolutely safely. You can't be doing this kind of surgery in a dangerous way. And I think that, a lot of, I'm not going to say unplanned surgery, but maybe before it was fully understood what they were doing, perhaps some of these screw placements you would hopefully never see if you had a training program that took into account this is how you put the screw. And you can absolutely minimize operative complications. We spend our whole time doing it. You have to understand the complications first.
Yeah, I think that's a larger discussion, screening and that type of thing.
It's a larger discussion,
but it's an interesting. I think it's going to, if we're doing this type of treatment for smaller curves, it's going to become more of a question in the future, isn't it? I think that's probably all we've got time for. I think that's been really useful. Thank you very much. Thanks for everybody who's contributed with the questions as well.
Thank you.